You're listening to the ReThink Health podcast, hosted by Dr. Marius Gianta and powered by the Center for Innovation in Medicine, a European research and innovation organization. Through this podcast and the ideas expressed by our guests, we want to build forward better and to set the stage for the European Health Union, one in which the Eastern voice is also heard.
So, hello everyone, I'm Marius Gianta. I'm the president of the Center for Innovation in Medicine and the host of the ReThink Health podcast. And now, today, it's my great pleasure to introduce you the former president at the Thomas Jefferson University and CEO at Jefferson Health, Stephen Klasko. Thank you so much for being with us in this podcast today.
Well, it's really a pleasure, and I think, by the way, I love the word rethink because I use reimagine and rethink all the time because we can't make incremental change in healthcare. We have to rethink every assumption we used to have. So I congratulate you on the title.
So thank you so much. So we were inspired to choose this name for the platform and as well for the podcast. Back in 2019, right before the pandemic, I attended the European Health Forum in Gastein, and the main presentation at Gastein that year was yours about the Jefferson, I may say, system, because it's not just about health, it's as well about transformation, it's about education, are a lot of ingredients actually you rethink when you manage both the university and the Jefferson Health. So let's start with the beginning and how. When was the moment, the aha moment for you, when you said, I should go to rethink different things and to change this and this and this and this?
Yeah. Well, Marius, I've had, and I'll do them briefly, but I've had three aha moments. One was, I started my career as a practicing obstetrician, and back in the 80s, 97% of obstetricians in the United States were male. The most performed procedure in the country was hysterectomy followed by C-section. So I happened to be, I hadn't done anything academic at that point. I happened to be at a lecture, some old guy, probably my age now that I think about because I was only like 30, but, talking to medical students saying, hey, if you see a small fibroid in the uterus, just take out the uterus because the woman doesn't need it. And I happened to be at Barnes & Noble that night, and 4 of the top 10 nonfiction bestsellers were What My Hysterectomy Did to Me, Hysterectomy Hoax, How a Hysterectomy Ruined My Life. So I realized that what we were teaching these kids was based on the past and not what patients were really thinking. Long story short, I did some of the early work on psychological and sexual effects of hysterectomy, et cetera. So then fast forward to the 90s, all doctors are complaining about the business of healthcare. And I said, look, I can deliver a baby. I can probably figure out business. So I got my MBA at Wharton. I got $1 million grant to look at what makes doctors different than, depending on your audience, either other people or normal people in how we handle change, and recognize that we need to educate and select doctors differently, not just based on being able to memorize the Krebs cycle, but being ready for a future and ready to. We came up with the way we select and educate docs. We joined a cult around 4 biases: autonomy, competition, hierarchy, and non-creativity, none of which are good in a changing world. And then the last one was I got to lead the digital health initiative for Apple pre-iPhone. Obviously did not keep my options, but that was about 87 splits ago. But if you remember, Apple was a small computer company with 3% of the computer market and, 4% of the operating system market. And Dell, Gateway, Microsoft were the kings. And if you asked any of those folks what's going to be like in 2022, they talk about cooler laptops or Windows 2025. Steve Jobs recognized that their whole piece was getting commoditized, the computers and operating systems. That I don't want to spend the next 10 years just incrementally changing. I want to create a digital lifestyle. So that's frankly what I took to healthcare. I said, look, when I became the CEO of a very conservative, I won't say failing, but certainly not doing great place. I said, look, why don't we steal the Steve Jobs model? We talked about the old math being inpatient revenue, outpatient revenue, NIH funding, and in-person tuition. The new math being healthcare at any address and strategic partnerships with digital companies. We talked about healthcare at any address. By the way, I got the same reaction Steve Jobs got, like when he said, "I'm going to move money out of computers and operating systems to this digital thing." Hey, dude, our whole revenue is computers and operating systems. I got the, "Hey, Steve, if you give us more money for NIH funding and get us a proton beam, we can get closer to University of Pennsylvania in U.S. News and World Report." And I remember saying, I'm a short, bald guy. I remember saying, "Hey, if that's what you want, it'd be like if the search committee said height and hair are the most important things. Let's think differently." So our moniker, to your point, became, could we be a 197-year-old academic medical center thinking like a startup company? And frankly, that's really what changed things. That was true in our university. We merged the number 3 design university in the country with a 197-year-old health university. People thought that was nuts. Well, wait a second. Design of the human experience in health. That might not be such a crazy idea. So I think that some of these ideas that in 2013, I invested $35 million in telehealth in 2013. A lot of those things are not crazy now. So, Maris, you've been in this thing for a long time. There's that fine line between crazy and visionary. And, people like you and I are always straddling the line. And, I've been proud to straddle that line.
So it's so easy, to say, and this is actually the truth, that the university, 100 years old, with a startup mindset. It's very easy to say it. It's very easy to see this happening, actually, in fact. But what were the main challenges? Because you have on one side this inertia. I think inertia is it's always close to academia. I don't know why, but it is there. And this is the academic inertia, the clinical inertia, maybe sometimes the patient expectation that follow this type of inertia. How did you manage this or other challenges at the beginning?
Yeah, it's a good question. I think I'm old enough and smart enough to know that some of it is timing and some of it is luck and some of it is a vision. So, you always start with the vision. That would be my one suggestion to everybody listening to this. So, when I first got to Jefferson, there were 5 academic medical centers in Philadelphia, and every one was to be the premier academic medical center in Philadelphia. And I thought, like, who the heck cares about that other than you and your mother, right? So we changed ours to we improve lives. Now, then the other thing I did is said, well, I can't just say that. So I made 25% of my incentive being reducing health inequities in Philadelphia. All of a sudden, that sent a signal that we were going to be different. And then what I did, so when I did telehealth is a good example. That was using blunt force. I went to every chair and said, and again, this is in 2013 where, telehealth was like Satanism, like what are you talking about telehealth? We're a hospital company, and so I went to every chair and I said, you're going to have to get 80% of your faculty trained in telehealth and doing at least one a month for you, chair, to get any of your incentive. 17 of the 18 chairs did it for their own self. They thought I was crazy, but they did it. The other one isn't with us anymore. Well, he's in the earth. He's just not with Jefferson anymore. So the fact is, but then once they started to do it, they recognized, boy, this is pretty cool. And it became their idea. So some of it is blunt force. And then the luck part is, look, Jefferson had averaged $20 million a year in philanthropy, before I got there. Within 4 months of my creating the vision, whatever, I got a gift from Sidney Kimmel to name our medical school for $110 million. I got a gift from Bernie Marcus, who's the founder of Home Depot, around integrative health and global health for $60 million. Why? Because I wasn't afraid to talk about things like, wait, we don't do everything right in the United States. Like if I go to China and I hurt my back, I'm not going to get a Flexeril or Motrin. I'm going to get Ayurvedic medicine. Here, and acupuncture. Here, if I talk about acupuncture and Ayurvedic medicine, everyone goes, oh, lava lamps and beads. No, it's just a different way of doing things. So the fact that I was willing to say that, and as a president of a university and CEO of a storied health system, got people like Bernie and Sydney to say, wow, this is something I want to invest in. But that's where it becomes a positive feedback. So then people nationally say, wow, Steve just got Jefferson $110 million gift from a visionary guy like Sidney Kimmel. We ought to look into that. So I think, I got us out of a 20-year merger we had with an entity called Mainline Health that just didn't make any sense. Everybody said that Jefferson would go bankrupt. But the fact that I was able to do that and we did okay with Moody's and Standard & Poor's, just sent a signal that I was going to make some bold moves and at least at the beginning succeed. So I think it takes vision, it takes execution, it takes communication, it takes some luck, because if anything had happened bad at the beginning, I mean, people were betting on my tenure, in months, not in years. So I think that by the way, that wasn't, and I'm not comparing myself, but that wasn't untrue around Steve Jobs either. Like when he first came out with the iPod, the stock went down 25%. He's building that company around an MP3 player. So I think the biggest problem, and answer your question, is that vast middle. So what I did, I changed almost everybody that reported to me, because the chances that you would want to be part of a leader in an organization that was basically the place where good ideas went to die and was the most risk averse in the country, you still want to work for me, were zero. I changed everybody that worked for me. I got like some really good people coming in, like the telehealth group. We had the largest specialty telehealth group in the country. All 6 of them came from a competitor. But it's why? Because they recognized that our vision was becoming to reimagine healthcare to create value. And they said, where I'm coming from, I could win a Nobel Prize for telehealth, but my president's vision is becoming number 1 in NIH funding. We're actually reimagining, we're doing exactly what your vision is. So I got the people coming there because they love the vision. I changed the leaders, but then you have those 25,000 people in the middle. Chairs and vice chairs and directors and managers that have been there for 30 years, especially in nonprofit academic things, that have watched presidents come and go and strategies change. And, it was like, all right, well, this guy's, I'm not going to basically jump in the pool of this guy's either crazy or visionary, but I want to be okay if he's here for 3 months, and I want to be okay if he's here for 10 years. So I'm just going to hedge my bets. I'm a hedge fund. And, it was hard to move forward quickly when you had chairs hedging their bets. I had, so I'd say 3 things. If I was going to answer your question, so I said radical collaboration, radical communication, and a radical sort of concentration on creativity. And with the operative word being radical and not incremental.
I like the word radical, and I think it's not a surprise. You mentioned the vision, the execution, and you mentioned the communication. You actually mentioned 2 times the role of communication, which I think is really important for a leader. But maybe you can discuss a little bit more about this, because I think it's the role of communication, especially in relation with the rethink, reimagine, the transformation of health. The role of communication is underestimated, I think, and we have seen this as well in the pandemic, with a lot of people actually saying things about the virus, about the pandemic, but not communicating actually.
I'm so glad you brought that up. So the answer is yes. I think it's the single most important quality for a leader in a time of turmoil. So, I started my career as a DJ, Marius.
As a DJ.
Yeah. My major was broadcast journalism. I was a DJ. I got fired, and my minor was chemistry. I became a doctor. And actually, my 6th book is coming out in November, and it's everything I learned from being about being a healthcare leader for 40 years. I've learned from being a DJ for 45 years, and it's actually called "Staying Alive." Based after the Bee Gees song, "Staying Alive: How the Message of Music Can Make a Healthier America." Every chapter has a song, like "Courage to Change" by Sia, that we have to keep the customer satisfied by Simon and Garfunkel, around consumerism. But so you mentioned the pandemic. So what I did was, I had 35,000 employees that were going through a pandemic. It was like a war, right? Because they were going to work and they had to go home, and it was horrible. We didn't lay off or furlough one of the employees because we recognized that this was their life and their livelihood. But what I did was, every Friday I did a playlist. And that Friday playlist became the lifeline for my employees, because we were going through this trifecta of the pandemic, sort of a financial tsunami at one point, because of no elective cases and stuff, we were down $1 billion, whatever. And the whole racial re-reckoning, because we were one of the centers for the George Floyd stuff in this country and that kind of thing. But I hit all of those with playlists, right? Everything from the real serious, like when the George Floyd protests were happening, there's a Curtis Mayfield and the Impression song, Choice of Colors. And my 35,000 employees start to use that as a way of communicating with me. Yeah. We actually ended up on the Ellen show, the Ellen DeGeneres show, because Sia, the artist, had this thing for a song she did about Level Up, and my nurses won the dance contest and the karaoke contest because music was so much a part of our response. So but then some of the stuff was fun. Like as the surges became a little less, I did a whole thing on, for any of you that are back dating, I used songs like First Time Ever I Saw Your Face by Roberta Flack, because all you saw was people with masks, and now you got to actually see the person. But then the other place where it was communication, we had one of the highest vaccination rates among African American and Latino folks. Why? Different communication. I went on a radio show every Sunday. It was predominantly an African American audience, and I listened. I didn't talk. I listened. And at one point, I got this great text, Marius, from somebody that said, clearly an African American family. We don't usually trust people like you. I figured that was short bald people or something, but we don't usually trust people like you. But you seem to be really sincere. And Sonny Hill, who was the person that runs that show, likes you. So I'm going to get my whole family vaccinated. So we had about an 85 or 90%, and we called it #RealTalk. We went to African American churches, we went to Latino churches, and we didn't preach. So I'll give you an example, because a lot of times we think, oh, these people must be stupid, whether they're, mid-country Republican folks or whether they're African American folks in urban areas. So one of the Latino churches, the reason I'm not getting a vaccine is they put a GPS in your vaccine, in the vaccine to monitor you. Wait a minute, so, but that's stupid. Well, actually, it turns out that Bill Gates had done a TED Talk on that back on the H1N1 flu hit. That, hey, it wouldn't be a bad idea to maybe put a GPS so we know where people are. This is before all the politics of the pandemic. So the concerns that people had were real, and they just wanted real talk back. An African American church, well, I'm not getting one because I hear you have to use an aborted fetus for the vaccine. Well, not stupid, not correct. It's a fetal stem cell line that led to the mRNA work at University of Pennsylvania that led to the vaccine. So once I explained, well, yes, that probably started with a 1978, aborted fetus stem cell, but that it's not like every time we make a vaccine there, so I mean, and those people really appreciated that we listened and et cetera. So I think, radical communication, whether it's an individual patient, I've delivered 2,500 babies. I made a playlist for every one of the people I delivered. And I think my practice grew because I talked to people like people, not patients, right? 97% of people, if there's one thing that people listening to this, if you want to build something in healthcare, the one suggestion I'd give you, I now work for the largest digital health company in the world, General Catalyst, the guys that started Livongo and Airbnb and Warren Parker and Stripe. But, don't view people as patients. 97% of people in Philadelphia, they might have diabetes, cancer, heart disease, whatever. They don't wake up in the morning and say, I'm a patient. I'm a person who would like to thrive without healthcare getting in the way. That's what we haven't figured out yet.
Yes, we share the same vision related to this not relation, this reality that every person, it's a person. Every individual, it's an individual. Then maybe it's a patient, but you have to talk with him, to explain to him to a human being, to a person. And this lack of communication, or bad communication, or discommunication actually made a difference in the pandemic. I would like to enter a bit into details, because you have a lot of reflections and a lot of initiatives around the empathy, around the emotional intelligence, and how important is this for a doctor as well in the relation with the others. But let me first tell you that I haven't been a DJ, but at the beginning of the pandemic, for the first 6 weeks, I have been every morning at a radio show, the biggest in Romania, trying to explain real time to the audience. 1 million, we are 20 million in Romania, so you can manage. You mentioned that the audience was higher. Trying to explain in real time what is really happening, something new as well for me. But the power of communication, it's very important, and the way you discuss. And I remember the controversy around the wearing a mask or not was the opinion of WHO. I said, of course, we should wear a mask. If you have one, just wear it, because this will increase the risk to be infected. But coming back to empathy, you're working now for a digital company. You refer.
I have 4 jobs, but I'm an executive in residence for General Catalyst, which is a very large digital health company. I wrote a book called Unhealthcare: A Manifesto for Health Assurance with the managing partner, Hemant Taneja. Hemant's the guy that started Airbnb. And he had written a book called On Scale, what got us together. If you think about Airbnb, Warby Parker, and Stripe, it used to be if you were going to build bigger, better hotel chains than the Marriott, you had to build a hell of a lot of hotels. The idea behind Airbnb, let's not build any real estate, let's bring people together. Same thing, Warby Parker. If you were going to compete with LensCrafters, you had to build a lot of mall stores. No, so I tried to take that into healthcare, and that's where we created the Health Assurance Network, which is what I help run now. So I work for them. I'm the North American ambassador for Sheba Medical Center in Israel, which is number 10 health system in the world. And I'm an operating partner and chief medical officer for a company called Abundant Venture Partners, which is a very socially conscious group. And then I'm leading this really exciting bioprinting initiative. The concept of taking 3D printing, but taking stem cells and stuff. So we've been able to create a post-breast cancer breast, where we can take a woman's breast cells and again, not use water or silicone, which don't really work with, but actually use women's own cells. So I'm trying to look at, take that Apple approach of what's going to be obvious 10 years from now and do it today. But the thing I'm most excited about is what you brought up, and what I brought up at the European Health Forum, is that we still accept medical students based on science GPA, MedCats, and organic chemistry grades. And somehow we're just amazed doctors aren't more empathetic, communicative, and creative. Like, duh, right? So it's honestly asinine. And one of the things, if you remember that European Health Forum, right after I gave that talk and thought I was being really cool and really radical, there were 4 students from different countries. One was from Belgium, I think one was from Romania, but whatever, they got up in panel. And the first student says, I can't tell you, but I really believe that Dr. Klasko is really wrong. And I thought they were going to say we need to be more conservative. We don't need to disrupt the medical education system. We need to basically tear it apart and start over. So, the fact is, think about how stupid it is that we still ask me to memorize the Krebs cycle as the gating mechanism to get into medical school. And by the way, that's why there's not more diversity. I mean, there's so many things about that, that when my supersized iPhone can do that better than anybody else, pretty soon there's going to be a robot next to me. And when I deliver a baby, it's going to take a picture of that baby and say, exactly what's wrong with that baby. So I would argue that, you have to have some science basis, but who gives a darn if it's a 3.8 or a 3.4 or a 3.2? And so the way I'd look at this, Marius, is that we accept every medical student like they're going to be a physician scientist at Yale.
Yeah.
The problem is only about 2% of doctors are actually physician scientists at Yale. The rest go out to Allentown, Pennsylvania and Canton, Ohio and practice. And part of the study I did when I got my grant after Wharton was we found out that doctors practicing 3 years or less, and we said, so how did we do? Taught me 70% of what you taught me I didn't need. And the 70% I need, you didn't teach me. You taught me a whole lot of microbiology and biochemistry and this kind of stuff, which isn't really helping me in my family practice in Canton, Ohio. You didn't teach me how to manage change. He didn't teach me much about health equity. He didn't teach me much about the fourth industrial revolution of AI, drones, robotics, genomics, et cetera. He didn't teach me anything about communication. By the way, that was about half of my Wharton MBA was, I'm going to be a leader. How do I communicate? You didn't teach me much about collaboration. You didn't teach me even how to run an effective meeting or how to market my practice or how to make patients happy. You didn't do any of that. You taught me a whole bunch of formulas and that kind of thing, which, by the way, now my computer does. So yeah, I think that one of the things that I'm proud of, I started first medical school in the country when I was in Florida that chose students based on self-awareness, empathy, communication skills, and cultural competence. It's going on for 10 years. And those are the doctors that I want to see, frankly, not the doctors that are admitted at university or wherever because they were able to memorize some stuff and did some good research. By the way, we need some of those people. I'm not, it's great. I want, the guys that are going to invent the next vaccine need to be 3 nines in science. But that's not who you need for your family practitioner or your OBGYN.
Yes, I was so naive when I go to the medical school, and I'm still naive, to believe that having empathy, being able to recognize the other's emotions and to cope with them and, to understand the emotions, it should be an intrinsic part of each medical doctor, but it's not the case. It's not the case. So we have to somehow change the paradigm to start teaching the medical doctors how to become empathic, right, with the patients.
Yeah. Well, we have to. I think some of it is. I'll give you just a real short example. We would take applicants in this program to an art museum, and we would basically show them this abstract art. It was a woman in a white wedding dress, a guy in a black turtleneck, and a snake. And we go to the applicant and say, "What do you see?" I see a woman in a white dress, guy in a black turtleneck, and a snake. I said, "Well, I know that. I can see that too. But tell me, what feelings you're having. Tell me, what it's emoting to you." And there were some applicants that couldn't get through the white dress, black turtleneck, snake. Others would tell the story. And what I tell people is, it doesn't matter what the story is. The fact that they could think beyond the visual. And and so people go to me, "Steve, why does that matter?" And I say, "Look, I've delivered 2,200 babies in my career. And it's pretty easy delivering a normal 28-year-old, a normal 8-pound baby. I mean, easy for me to say. I'm on the other end. For the women in the audience, I don't want you to think it's easy for me, but it's medically easy. It's incredibly difficult delivering an unscheduled Down syndrome baby, and this is why that emotional intelligence matters. Every case of that, the first question from that mom is going to be, "Doctor, what does this mean?" And I've watched analytic folks that can memorize the Krebs cycle immediately go into the what's chromosomally wrong and what the medical complications mean. I've watched really good self-aware, empathetic doctors, and I like to think I was one, recognize she doesn't give one darn about what's medically wrong. What does it mean to my image of a perfect baby? And right away we'll say, "This is a beautiful baby. I'll get you together with other people that have beautiful babies like that." That 30 seconds is how that mom, in some cases that dad, imprints with the baby. And here's the rub, Marius. In 5 years, there's going to be an IBM Watson or Google Brain or something next to me that will take a picture of that baby and be better than any human on the planet. Yes, Harvard, Yale, Princeton, even you, that being able to say, based on that phenotypic results, this is what's genomically wrong. I don't care who you are. But the robot will never get what does it means what does it mean to my image of a perfect baby. That's going to need the human doctor. So it took us 50 years to get doctors and nurses to work well together. Now we're going to have to get doctors and robots to work together. So when I was at Jefferson, I started the first center for intersentient education. We have all these centers for interprofessional education. I said, we're going to have to start these centers for how do we get the sentient folks like humans, like us, to not be fighting the robots, because the robots are going to think they're smarter than us. But we're going to say, but you don't have the emotional intelligence. So I figured I'd be ahead of the pack and create that first center.
So you mentioned how half century, took for the doctors to start working with the nurses. We don't know how many years it took to work with the robots. But when actually the doctors will start to work with the people, not with the patients.
Yeah, well, yeah. No, look, I think what happens is, so look, we, the whole book From Sick Care to Health Assurance I wrote with Hemant really started to look at this. we just have an asinine way of doing things. If you think about so my car, Marius, gets better care than I do. Okay. So
Yeah.
it hit me because I had my physical today. That's partly why I had to, we delayed this by a little bit. But I started my car because it sends continuous signals when it's in the garage. I started my car and it basically said, "Hey, Steve, while you were sleeping, my right front passenger tire got a little low. Could you fill me up before you do anything else?" Okay. I went my physical. Of the 15 minutes, 12 minutes was collecting data that probably should have been collected at home. And then basically it was, "Okay, Steve, this is what you should do for the next year." Now think about that. My car is sending data every day and making decisions every day. I'm a pretty complex organism. I'm 68 years old. And based on my today's blood pressure, my today's pulse, my today's calcium score, and my today's labs, this is what I should do for the next 12 to 18 months. So the simple answer is, what needs to happen is we need to use AI, drones, robotics, genomics, et cetera, to basically collect continuous and seamless data and analyze it. It's not about data, it's about actionable data. And then when I see a doctor, I need a human. I need a human that the data and the robot wouldn't get, saying, "Hey, Steve, I noticed you just left Jefferson and you moved from Philadelphia to Miami. Miami, that's a lot of sun. What are you doing about your skin? And how's that transition been? You were the CEO of 50,000 people. Now you're sort of hanging out. My guess is your wife isn't catering to you the way that your employees. That's what you need, a human to be asking you. I mean, as it turns out, I'm doing fine, thank you. But am I depressed? Am I, if I'm overweight, why is that? Not, oh, let me spend 10 minutes of our thing doing a blood pressure that I could have done at home, or a pulse that should be going all the time from my Apple Watch. So I think that's where that human interaction becomes, and I shouldn't need somebody to just be an incredible analyst of looking at my metabolic screen and telling me what's abnormal, because I know what's abnormal. I mean, like I get that on my chart. Okay, normal and age. Okay, oh, that's high. Okay, my hemoglobin A1C is high. Okay, like I don't need somebody to spend 5 minutes going through that. If my hemoglobin A1C is high, then what does that mean? Am I pre-diabetic, or is it just my diet? That should be honed in by the time that human sees me. They should be asking me questions about things like my behavioral health. That's the other thing. This whole issue of even calling it a physical, like one of the things in the book that we talked about is basically by calling it a physical, you're saying, I only care about you from the neck down. All right? I mean, why do we call it a physical? It should be like, Steve, it's a human. So the issue of, you want to check out your brain too, and so I could go in and have a totally normal physical, and tonight go home and want to commit suicide because nobody asked me anything about like how I'm feeling about life, or if I had a family history of Alzheimer's, and am I still doing crossword puzzles? I mean, I'd have to go to a brain health specialist for that. Well, that just doesn't make any sense. So I think as we start to create more empathetic, communicative folks, they'll think about the whole person. By the way, the first startup company I did was called Spirit of Women, because back in the 80s, we never put women's and health in the same sentence. Like, we only thought of women as organs. There was breast centers, there was uterus centers, there was fertility centers. And I started this company that now seems like duh, but it was like, why don't we think about women's health and have hospitals actually reach out to women? Like, we care about you as a woman, and you're different. I mean, I don't want to get into the politics of what defines a woman, but you're different. And it's not just you're different because your reproductive organs. You have different needs, you have different psychologies, et cetera, in most cases. So we'll create a women's health program. Well, that was revolutionary in 1982. Now everybody has a women's health program. But I think it's the same thing with a human health program. I want to go to somebody that wants to spend a half hour. Like, and by the way, it's not even a financial thing. Even these executive physicals, like they're like $10,000, you get everything, right? And then you go and they give you a little USB and says, Steve, you're a little overweight, you're a little stressed, you could probably, have a better relationship with your wife, your calcium score is a little high, this and that. And then they give you a really nice USB and a really nice report. And then you go next year, $10,000. It's the same thing. No coaching in between, no continuum. So to me, that's the key. If you care about your health, there should be some kind of seamless thing that goes beyond just the physical, that includes brain health, but that also includes all the omics. What are you eating? Well, your nutriomics, your biomics, your genomics. That's how we're going to keep people healthier, and we don't do that in the sick care system that is hospitals, which is I'll give you I was on a panel with the head of CVS. He says, even when you guys talk about data, it's laughable because you run 18 hospitals, Steve. If you're one of our quote patients, Marius, I don't know anything about you, right? Unless you came into the hospital. And even if I own all the doctors, all I know is the once a year you came as visible. And the guy from CVS said, look, you think you know your patient? I know a lot more about your patient. I know if you bought eyeglasses at the CVS. I know if it's a woman, or if it's a man, if he gets condoms, or if he's having I know just about. I know like what birthday cards he's buying, and I also know, when he buys food, is he buying protein bars or is he buying, Rolos, right? And that's really his health. So one of the things I'm doing now in my digital lifestyle world is working with some of these consumer companies. And again, we do this based on patients' desire, but like there's consumer companies that know what you do in Dunkin' Donuts, right? And I did a study where I found out if you send somebody home with congestive heart failure, their best chance of getting readmitted is how many Domino's pizzas they order. Because you put them on a low salt diet and they're willing to let me know what they ordered. And I found out the first week they ordered 3 Domino's pizzas. My guess is they're not keeping their low salt diet.
I fully agree. As a person that is interested in personalized medicine and personalized healthcare for many years, I'm fully agree. But how difficult it is to really implement this? Because you mentioned, of course, the emotional intelligence, the artificial intelligence, all these digital, let's say, tools, but call it this type of intelligence. Of course, the cognitive intelligence of each doctor should be a requirement, so should be something mandatory as well in the future. So we have this triangle of 3 types, let's say, of intelligence: the artificial one, the cognitive, the emotional intelligence, and the aim to put them all together in order to provide a more personalized approach to each person, right?
I don't think it's that hard. I think that it's well, first of all, you have to change the payment system, and you probably have a global audience, so it's hard to. But I mean, the American healthcare payment system is you couldn't come up with a more screwed up way of defining health, right? It's like there's a Upton Sinclair quote: "It's hard to get somebody to do something when their salary depends upon them not doing it." In one of my books, I talked about, and it sounds like a joke, but it was true. One of the health systems I was CEO of, they had this big fair right next to the hospital, and how fair, like state fairs, and like it was all serving corn dogs and funnel cakes and deep fried stuff, and literally it was sponsored by blank hospital cardiovascular department. Now it sounds like a joke. But under it's hard to get somebody to do something. Their salary depends upon them not doing it. If my community got a hell of a lot healthier, I'd go bankrupt under the sick care system. Now that sounds weird, but that's true. If you really want to know what's really weird, that is almost unconscionable. When the Affordable Care Act came out, and President Obama said, we have to move $1.25 to $1. If you knew anything about economics and market dynamics, you would have sold all your middleman stocks. They said, well, to move $1.25 to $1, what does every other sector do? Takes away the middleman, makes things simpler. The best stock to have bought since the ACA came out, other than Apple Computer, was United Healthcare. So wait, how can a middleman that gets 17 cents on the dollar to make sure that people that pay for the care, get the care, and provide the care can't talk to each other, end up ballooning like that? And then if you really want to see the perversity, and I'm not picking on insurers, even though it seems it, but I will, is that insurers during the pandemic had their best quarters ever. And by the way, if you listen to some of the, in the United States, blues CEOs or even the for-profit ones, wow, how did you have a $6 billion quarter? Well, it was great because we got all the money in at the beginning of the year. People didn't get care. Now, I mean, that's true. And that's how it is, because if I can get the employers to give me X and I only have to spend half of X, I'm making a lot of money as a middleman. But that's so against where the rest of the retail sector and every other sector is going. So I think part of it, Marius, is payment. Part of it is I think that the younger generation, the millennials, Gen Zs, are going to have their mad as hell, I'm not going to take it anymore moment. I mean, I think that, so I'll give you an example. My daughter got pregnant during the pandemic, and she needed 3 non-stress tests, 3 monitors a week. So she calls me up one day and says, hey, Dad, I had to go to the hospital 3 times a week, pay $35 to park, go to the hospital. There's just a whole bunch of sick people, go up in an elevator, people are coughing. And by the way, I'm sitting there, they put a monitor on me, I'm staring at the ceiling. Nurse comes in 2 hours later, tells me my baby's okay. I thought you were the digital dude. Like, why can't I do this at home? Well, she's right. I am a digital dude. And I was on the board of a company that's doing it home. Why hasn't it happened? Well, a couple of reasons. First of all, hospitals make a whole lot of money, by having people come into the hospital. So the doctor that's paid on RVUs would get paid less, right? We have 2 malpractice attorneys for every doctor in Philadelphia. So the first time somebody got monitored at home and the kid that I delivered didn't get into Princeton 16 years later, because you have 16 years to sue me, literally I'd get sued because they were monitored at home. So we have these perverse, however else you want to put it, we have this perverse thing. So we really don't want to change it. We don't want to change it. We're one of only 2 countries in the world that allows contingency things. You can sue your doctor, you don't have to pay us. So that's weird. We're one of only 2 countries in the world, different countries, that allows direct-to-consumer farm advertising, right? So you want to look at something really weird, folks out there, if you're in the United States? Notice why, I'm old enough to remember where pharma could not do direct advertising. But then when it first started, it was always things like Advil or Viagra, or, like lifestyle type drugs. Now, half of them are, do you have stage 4 lung cancer? Now think about that. Why would you be on a morning cable show? Do you have stage 4 lung cancer? There's not that many people, thank God, with stage 4. It's because the drug is $400,000. And the drug only really works on about 10% of people. But now everybody goes into my pulmonologist and says, hey, I want that drug because that guy isn't wearing oxygen. He's frolicking in the weeds. So, I mean, the fact is, we have this almost Monty Python-esque system. And then we're amazed. Well, I don't understand. Why do we have a $4 trillion healthcare system, but our maternal morbidity and mortality, or our neonatal morbidity, is like somewhere in the middle of the pack? Why do we spend more per obstetric patient? Well, it's simple. Because I just mentioned my daughter, who had the inconvenience of paying $35 a week, but somebody who's an essential worker that can't afford to pay for parking or can't afford to get off from work to go to the hospital, she just doesn't get the testing. And then her kid ends up in the NICU. So you think about the social costs of that, but then you think about, wow, the hospital's getting paid a lot of money to have that person in the NICU. So I mean, it's just, we have this sick care system that promotes. The best way to look at it, I don't know how much your listeners are tuned to American politics, but I was on a cable news show and I said, Bernie Sanders, who's sort of more of the Democratic Socialist type party, and basically I said the pandemic proved he was 100% right about the problem, and the pandemic proved that he was 100% wrong about the solution, because his whole thing has been, we have this corporate, pharma-driven, insurance-driven, for-profit-driven, non-patient-driven healthcare financial system. The pandemic certainly proved that. the chief determinant of you dying from COVID-19 was your zip code, not your genetic code, not your doctor, your zip code. Okay, so Bernie, you get an A for that. I think the pandemic also proved, at least in America, that let's let the government solve the whole problem. You get an F for that. Jefferson existed in 10 counties in 2 states. There were things that I had to do in one county that would be against the law in another one. So the government, and you think about all the corruption with the PPA and that kind of thing, having the government run healthcare, it's easy to put 3 words together, Medicare for all. So you know what, Bernie, you're right about the problem. You need a different solution.
I'm afraid that you actually described the problems and the challenges not just in the American healthcare sector, but at least in few European health systems as well. And
Well,
indeed, the pandemic actually.
Look, I think what happens, there's no perfect health system. I spent time with the NHS in United Kingdom. The NHS has made, if you think about the iron triangle, Marius, of access, quality, and cost, if you remember your 9th grade geometry, you increase one angle, you got it, so the NHS said, look, everybody's going to have access to healthcare. That became their North Star. Well, okay, but what they didn't deal with is the bureaucracy, the cost, the delays for elective stuff. But nobody has to mortgage their house, because they had cancer. The American healthcare system is for people who are going to pay. We want them to have whatever they want. You hit your head and you want an MRI, sure, I'll give you that. It's not going to happen in the NHS, but if you don't have the right insurance or you don't have the right employer and you get cancer, you have to mortgage your house. So that iron triangle really plays. I do some work in Israel. They have a pretty interesting system because, it's a smaller country, but they have four major health payers. They have pretty much of a everybody gets care system. Germany has a really good system. I don't know much about, the systems in Eastern Europe, but, if there was a perfect system, I think we'd all use it. And we tend to exaggerate what's good about our systems and unexaggerate what's better about it. So people think that, oh my God, the NHS is horrible. I've read all these things about people waiting 18 months, to have, like their hip surgery. Well, they might have to wait 18 months to have some surgery if their hip isn't really bad. But then if you go to the United Kingdom, oh my God, I can't believe you come from the United States. People literally, if they're underserved, can't get cancer care or get different care. That's horrible. So we're both right. There's just no ideal system.
Good or bad, health system will change. That's for sure, because of the pandemic, because of the digital tools, because of new generation coming with different requests than ours, than yours, and our parents, and so on. We experience this crisis, inflation, and so on that will change. I think everything. But and this is my last question for the end of our discussion, Stephen. How do you see actually in 10 years? Not an ideal health system, but a functionable health system taking advantages of all these innovations in medical innovation, you mentioned genomics as well, omics, other omics, and data and technology, but as well a very empathetic, very close to every citizen health system.
Yes. So this is what I think. I think healthcare will go the way that banking has gone. If you think about, bank, we don't get up in the morning and say we're going to telebank. It's just that 90% of the banking went from being inconvenient in a bank to being at home. And I think we will get to that health assurance model where, I am sending continuous data, out. That where AI comes into play is if I have atrial fibrillation, I'm not worried about dying in my sleep because this T-shirt is constantly monitoring most of what I have. If something happened, where my heart rate went up above 160, I would get a little wake-up call. An ambulance would be on the way, and my doctor would be notified. That at the point that a physical, my once a year physical would be a doctor that's gone through my year's worth of data, has asked me some, really social and behavioral questions. The doctor's been chosen based on self-awareness, communication skills, etc. He's my partner. By the way, I've had a coach, once a month for a year. Doesn't matter what my salary is. It's better for the system for me to have somebody checking in with me once a month. That's a whole new job thing. And we literally have data analysts in the middle. And my once a year physical is, Steve, I've noticed that, your weight's going up. We've already set you up with this diet, et cetera, et cetera. And hospitals, there'll be less acute care facilities, be much more sort of assisted living facilities with the aging of the population. And, general acute care facilities will be ICUs, really, really, really sick people. The whole ridiculous 24-hour rule. If you're getting something elective, it won't be in a hospital. It'll be in a combined outpatient, inpatient, what I call space station between healthcare at home and the hospital. And, people will have much more control of their care. And I think what will happen from a health policy perspective is we'll have some enlightened healthcare where starting from the time you were born, first of all, when you're born, we'll take your umbilical cord stem cells and we'll keep them for you so that if you need a kidney, we'll just make you a kidney. That's something I'm working with 3D Systems. But the other thing is if you're born to a person of means, middle class or above, the new Social Security will be putting money into a health savings account that will just accumulate, starting from the age of 1. If you're born to somebody that's underserved, instead of Medicaid and that kind of thing, the government will put the money into your health savings account. So you'll never call somebody and say, "Oh, I have Medicaid" or "I have United Platinum," which automatically they won't know what you have because they won't know who put money into your health savings account. And then what you'll do is most of us will have money in our health savings account. So you don't have, quote, normal insurance. If you see your doctor, or even if you need a knee replacement, you'll pay for that out of your health science, your health services account, but you'll have reinsurance, just like we do for like home insurance, right? If you have a small thing in your house, you'll probably take care of it. But if, God forbid, you have a lightning strike and everything goes out, that's what you have reinsurance for. So you'll have reinsurance for anything that's going to be, let's say, if you're somebody of our means, $20,000 or above, but the rest of the stuff you'll take care of. By the way, it's exactly what underserved folks will have. It's just, again, that the government will pay for that insurance. So it's not like they're put into a separate category. And it'll be a hell of a lot less expensive than the fraud and abuse in the Medicaids of the world and that kind of thing. So, I'm just a birther of babies, Marius, but that's what I would do if I was for the world.
So your advice is not to invest in the walls for the hospitals, but in digital solutions that are always with us, with the people, are able to capture data, to collect data, to send them maybe to the cloud or to physical storage. We don't know how
I think my suggestion is invest in things. If you're looking at a perspective, does it sound like it has radical collaboration? Does it sound like it has radical communication? Does it sound like it has a radical concentration and creativity on health disparities? That's the 3 questions I would ask, and I ask that in my new roles when I'm talking to founders. Tell me what you do around communication. Tell me what interesting and unusual partnerships you're looking at collaboration-wise. Tell me what you're doing to reduce health equity. If they look at me with a blank stare, I say, go look at one of the other venture capital firms investing in you. If they answer that in some reasonable way, then I'm interested.
And on top of this, a radical conversation with Stephen Klasko today at ReThink Health podcast. Thank you so much, Stephen, for joining us. A real pleasure, a real inspiration for all of us to have you with us.
Thank you, Maris. I really enjoyed it. Have a great day.
You listen to the ReThink Health podcast, hosted by Dr. Marius Gianta and powered by the Center for Innovation in Medicine, a European research and innovation organization with interest in visionary health policies and civil society education. Through this podcast and the ideas expressed by our guests, we want to build forward better and to set the stage for the European Health Union, one in which the Eastern voice is also heard. The war in Ukraine, overlapping with the health crisis caused by the pandemic, changed our lives overnight, once again. We are all rediscovering the fear and the uncertainties of just 2 years ago, from the first days of the pandemic. We have a health crisis, but it is completely different from the pandemic health crisis. Naturally, not only health, but individual safety, from all points of view, has become and is now our main concern. At the Center for Innovation in Medicine, we are aware not only that we have not returned to pre-pandemic normalcy, but that we have entered the new post-pandemic normalcy. We are experiencing a new reality. Science and innovation do not stop because the war has begun. And nor will we.